thanks for this opportunity to interact with all of you. I'm very happy also that probably I am able to interact with people, doctors in Mumbai, where this disease is quite common. It's always a pleasure to talk to Dr. Shetty, always smiling and very helpful in nature. Thank you, sir, for your kind words of introduction. And also got a new friend, Dr. Ramaya, in this webinar. These times of social distancing and these tough times, we are supposed to follow social distancing, but still, nobody can make us socially isolated because this sort of technology, media, webinars are all helping us to keep a contact with each other and try to do what is good for the patients. And the topic, why it was selected for geriatrics and cardiovascular disease, was already briefly mentioned because these two are subgroups of patients who have maximum problems happening with COVID infection. So what I was supposed to speak is regarding how we are dealing here and also touch upon some ESC guidelines which are recently launched for the management of this COVID patient. This slide brings best wishes from Apollo Group of Hospitals, and I'm proud to present our FACS professional services colleagues, especially the FACS team at Apollo at the top. I'm very happy to share that a lot of cases which we come across are all done in a team effort manner, and this is the best way in these tough times to lead and give patient care. I also run services in multiple hospitals which are shown here. We are a team of over 27 cardiologists, 3 surgeons, run in multiple places, an hub and spoke model. And this was appreciated in European Heart Journal too. And Apollo was also quite happy before. But now we are dealing with this different problem of COVID. What I would briefly do in about 15-20 minutes from now is actually, sir also requested me to show some cases. So what I thought is basically introduce with a positive note about emergencies and ACS cases, as briefly told that they have decreased in this COVID era. And then mention about COVID virus structure, pathogenesis, and what is some cardiovascular disease, how it is progressing. Briefly mention signs and symptoms. The general ones are already told by Dr. Amaya. I'll try to concentrate on cardiac manifestations and diagnosis of COVID testing, partly told by previous speaker, and how we'll evaluate cardiovascular disease in these patients. And what are the management pathways in ER as well as for management of these acute cardiac conditions and the structural heart interventions we'll mention here. And then personal protection and the protection of workspaces, equipment, what is all required, I'll try to cover upon, and spend some time in showing some interesting cases which we came across, both in COVID suspects and some COVID positives, and then conclude in the end. Then coming to the positive note, which I mentioned is, when we observed our ER admissions normally in our Apollo here, maybe we used to have about more than 1,000 admissions before in February or so. In March, it's decreased to 700 cases, the 30% drop, and in April, it is decreased to 400, another 30% drop. It's also statistics were collected by Dr. Kaul and many others in the country also. We have noticed about 50% drop in cardiac emergencies. When we further went on to look in acute coronary syndromes, acute MIs, what were happening before, compared to 35-40 which were doing before, decreased to 12 in March, and maybe we decreased to 15 now in this present month. If you try to see what is the possible mechanisms probably for this, probably stress is the most important factor. We, all of us are no work stress, competition, productivity stress, or other things are less. That could be another important reason. And environmental pollution much less could be also contributing. And infections, because we are taking care, making ourselves clean, less of infections, less inflammation, those could be the causes. And maybe some other thing is because of worry of COVID infections, patients may not be coming. Some of them are coming very late, which I will show you some case examples. And the transport facilities are not there for these referral hospitals too. Sometimes this could lead to trouble. And probably home bonding and probably meditation, good food which we take, and all these also could be helping. These are all proposed reasons which you thought, but it is anyway good to see that even these tough times, the mortality didn't go up. Though little more mortality is happening with COVID, but other problems are less maybe. That's what is noticed, and it's good for us. Then coming to COVID virus structure and pathogenesis, this is a small thing, zoonotic virus, which basically has 4 RNA proteins, has 80 to 100 nanomicrons and a spike of about 20 microns. Such a small one is creating hell out in the world. These 4 proteins which you have here, the spike protein, then probably enclosing RNA, the membrane protein, and lipid membrane. people are trying the viruses, vaccines to be made available to these sort of proteins, whether to capsule or to the spike. And such a small thing which is contributing as creating very problems. Why it is doing so is this is a rather very active fellow. It doesn't waste its time. Once it starts, it spreads like hell. It started just in December and infected about 77,000 patients in China. Then it broke out to other parts of the world. Somewhere here in Wuhan, China, I hate to see such markets which are busy, especially vegetarian and fish markets and all that. But it originated there and became a pandemic, spread all across the world. You see, there's no part in the world probably in this map which is not there with this. Probably we are suffering more here because of close nature to China and other things. If you see, why is it again, as I said, what is the specific characteristics? The characteristic is high infective potential, highly transmittable. That is the only problem. It is actually, mortality-wise, it's not that a problem as shown in previous slide, but it is infection-wise, it is more. And young people, because of likely to be carriers, are getting infected, but less likely to die. And whereas fatality ratio, as told my previous speaker, is 4 times higher in elderly people. Women are again somehow protected. Men are getting more because of more exposure, various other reasons too. And if you see, this is what I'm saying, less pathogenic, to only death rates between 2 to 8%. In India, luckily 2 to 3%, compared to the other previous viruses which had about 35% mortality. And several cases are asymptomatic. That's where the spread is happening. And then that's how the government has decided social isolation, lockdown is the only solution. So that's about the nature of the virus spread and the structure of the virus. Coming to signs and symptoms in general and cardiac specifically, many of the times, first 2 to 14 days, there is a specific, non-specific symptoms that are asymptomatic. Some could have vague chest pain, palpitations, but this persistent flu-like symptoms and sometimes loss of smell and flavor is also noted. These are supposed to be red flags. If you see this slide, it shows fever is common in 88%, dry cough 68%. Some 30% of them could also have productive cough, fatigue, and breathlessness. If at all, if it happens, it is again more severe sign, and that is patient is going to more and more trouble. That's where they are presenting to the hospital, unfortunately. Headache, sore throat, chills, and like any other viral influenza, it is there. If you see this testing which we are doing, lymphopenia, leukocytosis, elevated D-dimer, LDH, PCR, these are for the mild classical symptoms. If he's again progressing rapidly, then you do other enzyme testing like ferritin, troponin, CPK, and liver function test, kidney function will start becoming more abnormal as the patient goes to multi-organ failure. If you see how are we diagnosing this virus directly, is basically we're taking it through nasopharyngeal swab or sputum swab. But the problem with this is also about it could have 1/3 false negatives. That is, initially, though he has disease, it could come negative. And as we repeat the testing, it could come positive. This is another thing by which the disease could spread more. And then in some of the testing centers where this is not available and some because of governmental rules where testing is not possible, which I'll be briefly touching upon, which is a state in our state, Telangana, CT chest imaging is again taking some role in diagnosing these cases. And HRCT is supposed to be sensitive to rule out viral pneumonia. Mind you, this again may not be sensitive if patient has not got infection in the lung. Then antibodies and viral load testing again is there. Then COVID testing, if you have to go further to see the testing, various test types, the nucleic acid amplification test, that is what is a PCR detection of the virus, that is supposed to be common, and individual testing has to be done, and the labs needs to be very carefully doing this PCR testing. Antibody-based testing with ELISATs, IgG, IgM antibodies, probably this doesn't need too much of technology, but this comes positive only after somebody develops immunity. The antigen-based immunoassays are also under study, and the clinical tests, what we said, symptomatology, and here comes the imaging with CT, again could help in this diagnosing these patients of testing. Then ICMR also released guidelines, and this what priority 1, 2, 3, 4 is of ESC, what is released, is basically a lot of criticism also happening, and we also have doubts whether testing is being done normally or not. The priority 1 testing is for hospitalized patients or symptomatic health workers. Priority 2 is for long-term care facilities, elderly people, because as we understand, there's more disease there. Priority 3 is again for healthcare workers and who are exposed. And the non-priority is individuals without these symptoms. Anybody cannot go for testing. It becomes too huge for the country. These are the typical lung CT findings, ground lab appearances which are having, and the crazy paving pictures which you see in HRCT. Coming to cardiovascular pathogenesis, if you see, the COVID virus initially enters through ACE receptor pathways, enters the lung, and that's how initially the worries of ACE inhibitor, whether to use or not, was there. It also affects directly the cells, macrovasculature, that is where you get a disease without much of a major vessel disease, or sometimes it could be macrovascular disease, that coronary arteries, plaque ruptures. And if it goes through the immunological pathway, cytokine activation, then you could get into more florid pictures of multi-organ failure. And as latest as yesterday, NEJM has got out released this thing of CVD mortality data of Brigham coming from Brigham Women's Hospital. Why I thought I should mention is it is the data of 169 hospitals, which is surgical registry of Asia, Europe, and North America. It is seen with 8,910 cases, out of which 515 were deaths. And what they predicted in this, as already told, is higher age, and presence of CAD, heart failure, cardiac arrhythmia, COD, and smoking were high-risk predictors. No relation with ACE inhibitor or ARB usage. Another two good articles came out in NEJM, again, the yesterday one, basically from Italy, which has 6,000 patients, and New York, which is about 5,900 patient analysis. Both shared that ARB ACE inhibitor usage has no higher risk and it should be continued. In fact, actually, ACC-ORG and Medscape also came out with data showing that if it is stopped, patients are having higher mortality, something like 10-20% increase. So there's no worry of ACE inhibitor ARB usage. Coming to the commonest thing which we tell immediately is ECG. Most of the times ECGs are abnormal. 93% you would have abnormal ECGs. Arrhythmias like atrial fibrillation, ectopics are noted. Right ventricular strain patterns are noted. Sometimes you also get pathological Q waves, and the QTC also becomes abnormal. That's where we need to be careful about using hydroxychloroquine. And the typical ECG patterns is what is mentioned here, RBB and the non-specific STD changes. Unfortunately, one of the patients I would show normal patterns of RBB also gives you some worries. Echocardiogram is again very important, as told by Sir, whether it is a MI mimic or real MI, regional wall motion abnormality, LV function, all that we assess. But what is more recommended in these COVID times to protect our equipment like this, and probably have a barricade like this if possible, and also protect the people who are doing it. What is recommended is, rather than detailed echocardiograms, basically point of care ultrasound testing, what they're calling is focus. This is what is came out from ESC also, to specifically look for particular things rather than doing a detailed echocardiograms like LV function, pericardial effusion, right ventricular function, or any valve regurgitation. So focused studies, very short studies, will help to do the job as well as to avoid exposure to both the technicians and other things. Coming to the management pathways in ER and STEMI, what is happening presently in Hyderabad and especially in Apollo Health Hospital, I can tell you, they have segregated totally to ID building, that is a fever clinic separate building, so that there's no mixing with the regular patients with this. And triaging, suppose anybody comes to a regular ER and then has a suspicion, he'll be sent back to that. And if it is a suspected COVID case, he'll be shifted to quarantine level 1 in isolated building. And if it found negative, he'll come back to regular ICU. If it comes positive, he goes more inside into a level 2 ICU care, or get shifted to government hospital as per the government instructions. Then anybody who has a suspected case, but with urgent cardiac emergencies, that is the dilemma. That's what the delays which you cover up. Then some of the patient risks, if it's a confirmed case, again, there's no confusion. We have to take all care. Probable case, suspected cases is the one where we are coming with the cardiac emergencies. We need to tackle the scenarios I'll be dealing with. The negative cases, again, there's no problem, but we have to protect them from getting infected. The algorithm with ESC mentioned is ER-access, is basically if there's no COVID infection, regular protocols. If there's COVID infection possible, then again, the same things of what we followed is being mentioned in this triaging. This, I thought it was interesting. Some of the hospitals started using robots for entry-level temperature testing, which is being followed. So again, less of manpower infection, but we are not yet there everywhere. The present pattern of case intake in the hospitals is basically private lab testing is not allowed in our state because of Telangana. I don't know what is the situation in Mumbai. We'll have discussion. But government designated labs only do it. So in hospitals, many of the corporate hospitals designed their protocols with CT chest. And if anybody coming, if CT is normal, then probably we are going ahead and doing what is best for the patient till the regular testing with PCR happens. So these management pathways, what we get depending upon it and how we are protecting, I'll mix up with these case examples to save some time also and take you through. Here's a 50-year-old female, hypertensive on treatment, came with actually history of breathlessness. She also had some history of pre-existing asthma. But in these times of COVID, it becomes a problem. Then the troponins are sent. But what you need to understand is unless troponin values go very high, generally you don't think that it is. But many of the 20-25% could have minor elevations of troponin. But whoever has a high troponin values are supposed to have a high risk. And this lady has this sort of ECG, gross STT changes with AV or ST elevations. We otherwise would have taken immediately for the to lab to check status. Then we were dildaling. Fortunately, we started antiplatelets and infusion, heparin infusion. Then she slightly settled. Then later, next day, when the COVID report came as negative, then we took him for angiogram. Luckily, then the coronaries are normal. Probably this is what is called as mild plaque here, the Minoca, what we call normal coronaries with ischemia. Then another elderly gentleman, 65-year-old, you see, this is the problem which some of these patients are facing. Hypertensive, diabetic, all typical, could have 4 hours, 4 days duration retrosternal chest discomfort. He was staying in the home, and gradually when he came to the hospital, we already had some few loss of R waves and ST elevations. Then again, the confusion in the hospital started. They said that we will have to do testing, but in the mean process, the patient had more pain, ST elevations, echo showed regional wall motion abnormality, chest X-ray showed such sort of pulmonary edema appearance. Then our ID people and pulmonologists all felt that it could be also COVID, but we went on saying that it's typical pattern of pulmonary edema and patient is worsening. We rushed to the cath lab and then probably took all the precautions which I will share. And then a tight LAD disease, which is again anti-apic renal view also doesn't show it. And I'm not going to details of procedure, but this is the appearance post-procedure. Again, patient had good result and immediately stabilized. These are the things which doctor was mentioning. Level 2 PPEs are what is recommended in cath lab. Level 3 is for directly people who are getting exposed to day-to-day infections. And to do procedure is level 2 APP is also no joke. It is very stuffy and you can't do that like in regular patient. There are definite donning and doffing protocols which are given for this for sake of time. I'm not going to details, but it's also not only very important for us to take care of ourselves with these personal protection devices and also take care of the teams. All the cath lab staff should be taken care, and the lab also should be again immediately cleaned as with recommendations. And only probably if you have 2 labs, one can be identified as a COVID lab as what we are doing, and probably take care of these patients. Probably if this is there as a stray news, I thought I would just project for the sake of interest. This is a robotic PCI where not many people are required to do the procedure, but for loading it onto this, probably there's some data which came from Einstein's Institute in US that they did some in such COVID positive cases. But unfortunately, we're not there. So a lot of PPEs, deficiencies were there throughout society. We mobilized some funds and donated this both in Gandhi and Usmania, which are government hospitals here. Then immediately after the procedure, ECG improved, patient stabilizes, pulmonary edema disappears. That's what is the classical of cardiac disease. And then patients gradually improved and got discharged later. Case 3 is another 50-year-old female, 50-year-old male, diabetic, chest pain of 2 hours duration, went to some other hospital, which was also one of our hospitals, which would have otherwise given PCI. But this confusion that to do it or not, some people are also initially, guidelines were also telling maybe do lysis also if possible. They did a chest CT and ruled out a significant problem and then gave tenecteplase place, but unfortunately patient had ongoing pain. Then he got it shifted to our place. That's a thing. LAD was totally occluded. After the procedure, we opened it up and patient improved. Some of these guidelines which came of SKY, ACC, and also European Society, I'll briefly touch upon, are basically if you have a definite STEMI, there is no confusion of STEMI mimic, and where you feel the benefit would be more with a large anterior MI, things like that. Probably primary PCI, taking care with level 2 PPE is what is recommended. But if a travel time is more and pharmacoinvasive strategy could be done, they are added. I'll show that slide next. Probable STEMIs and STEMI mimics where you can avoid getting exposed to cath lab, probably you can follow them up medically. Some of these patients were developing MIs on ventilators during COVID treatment or cardiogenic shock, out of hospital cardiac arrest. These are all futile grave prognosis, and there is no point exposing the lab staff to this. So medical management or whatever is recommended. And NSTEMI, unstable angina, if you're stable, probably conservative treatment. You can postpone CAG and revascularization later. But again, if hemodynamic changes happen, you are supposed to go ahead and do this. This is what is again shown in the same slide. STEMI, where you have all the lab facilities, primary PCI, and this what is specifically mentioned is about 60 minutes extra time delay in these COVID times is what is supposed to be taken. And then probably the same thing with non-STEMI, very high risk features, probably go stage to cath lab. Intermediate low risk, where you can wait, you can conservatively manage. This is another interesting thing which I borrowed from a good friend, Dr. Shishir Kodali here, who is seeing. We run this TCT program with him. They are suffering with the plenty there. Actually, we don't see that many TAVR severe aortic stenosis cases, but he is now director there for this, where they are doing only such sort of emergent cases of severe aortic stenosis, the obvious failures in class 4, they're doing it now, and semi-urgent and the elective ones they are postponing. This is another good graph which they developed. The risk of waiting of AS mortality is more than the risk of COVID infection they're taking up now. But on the other hand, if COVID infection risk is more, then probably they tend to avoid. So that is the interesting thing. And this circular diagram which they developed at Columbia is again quite good. I thought it is very interesting. With the procedural anatomy of TAVR wise, it is ideal to do it, not much of time taking. And then patient has a long life, again, not very sick elderly patient, but more of a long-term survival with, again, limited resources if you can manage, and symptom status in emergency, probably patient having more symptoms, you do those cases. So this is the pink one is what they're doing it immediately. Others are kept on follow. Coming back to our heart failure, there's another presentation in another lady, 29-year-old postpartum. Many times you would think of coming with breathlessness, you would suspect peripartum cardiomyopathy, and history of some lung problem, which was not very clear, was there before during childhood. But last trimester, breathlessness increased and worsened now, and then she comes to the hospital. Obviously, worried of COVID, has anxiety, hyperventilation. ECG shows some incomplete RBV. Again, worry whether that is that problem. Echo showed RARV dilatation, mild pH. Chest X-ray is done. This is what is X-ray. Then problems become more worsened for this poor lady. And then our ID people said definitely it will be COVID. And we did CT scan, which again throws some more light saying that probably a whole of left lung has some congenital problem. And luckily, this patient was treated in quarantine, level 1 isolation, COVID testing sent, and it came negative, treated with antibiotic and nebulization, settled, and then discharged. This is another sad story. This is what happens occasionally in some patients. This is actually a 70-year-old female, actually great fans of ours before the daughter and everybody used to say, but unfortunate thing happened to this family, has all the risk factors. And then on 23rd April, she has a chest pain. This ECG was sent to me in WhatsApp. Then I told some minor T inversions, looks like unstable angina, come for the management and probably will do it, but added antiplatelets extra, increased the statin dose. But again, they took some time because of worry of COVID and transport problems. And yesterday, early morning, I received this ECG claiming that this patient started developing more ST elevations. I thought, where is this ECG taken? What these people have done, this is the place where the patient resides. It's about an hour's drive, 1.5 hour drive from Apollo Hospital, Hyderabad. This patient went initially to nearby clinic, again, took an ECG there. Again, when the MI was diagnosed, and then when I counseled them, they started coming back. And about 1.5 hour day when they reached, this is near the outskirts of city, she had probably urgent VTBF and unfortunately succumbed. This is a lot of things also unfortunate because of this various problems happening. I wanted to show some two of classical COVID type of cases also before we end. And we had some 2 COVID cases which came late in the cardiac shock type situations, did not survive. But this is again, I brought out for a good friend, Dr. Ajay from Colombia, 2 cases coming. 64-year-old female, hypertension, came with chest pressure, had ECG changes like this, and echo, chest X-ray was all right. And the lung echo showed LV dysfunction. They did angio, had mild lesions, supportive therapy with IABP and dobutamine, patient stabilized and discharged on day 7. This is young male, 38 years, diabetic, acute dyspnea, fever, chest X-ray showed ground gas appearances, ECG shows some non-specific changes, and LV dysfunction severe, then acidosis, all that happened, changes developed like this, and then probably patient was going into more of shock, ARDS type of situation. They went to very high level, which is not yet VA, ECMO, stabilize this patient and probably sent home. This is the typical appearance of myocarditis and other pericardial effusion, which are seen in this sort of patients who have myocarditis. I think various case scenarios I try to show, and I am nearing my time. I have a few minutes exposed where probably what is recommended in this time is ICMR and ESC also said, as mentioned by the previous speaker also, all of us should stay home healthy and drink plenty of water, do little exercise, avoid negative messaging, don't get bombarded by social media, eat well, focus, and practice yoga and meditation. This is also being recommended now for early diagnosis, less symptomatic patients. And to conclude, in Indian scenario, probably prevention by social distancing, hygiene measures is the best. And lockdown cannot continue forever. Probably after this goes off, we may have slight increase in patients also. We need to be geared up. But unfortunately, as some new cases are there, but they're less sick, then other suspected cases to be managed as per guidelines. And any patient who have more benefit with acute MI, you should definitely go ahead and do PCIs with proper protection, protecting cath lab as well as ourselves. And India is great. Ours is God's own country. Be positive, do our best to save patients at the same time taking care of ourselves, staff, and families. Thank you for your patient hearing.